Hello, and welcome to Portfolio Assignment 7. This deals with primary care and chronic pain. We'll be talking about chronic pain, payer methodologies, treatments, treatment goals. We'll touch on the opioid crisis, and there'll be some final thoughts before we get into question and comments and the references page. So let's get started. Chronic pain affects at least 116 million adults in the United States, and it takes a tremendous toll in costs and suffering and lost productivity. Chronic pain for patients who suffer from it is very real. Now, payers look at two populations when it comes to coverage: those who are at the end of their lives and those who are experiencing pain related to an injury or illness. And we'll take a closer look at the numbers in a minute. Now, primary care is the access point for chronic pain care, and while health systems offer specialized pain services, the primary care setting is where most patients seek and receive care for pain or are referred to a specialist. Now, primary care that is based treatment of chronic pain is generally done with an IDT with very effective outcomes and managing costs. Now let's take a look at some numbers here. Now this is for back pain by the numbers. Now if you take a look, you can see that workmen's compensation costs associated with back pain are $20 to $50 billion per year. Total direct and indirect annual cost of low back pain is approximately 85 billion. 149 million workdays are lost due to lumbar injuries. And back pain is ranked first of the cause of disability in the United States with adults under the age of 45. And back pain is responsible for nearly 2/3 of cases of people missing work due to pain involving the upper body. And this is just back pain. But what makes chronic pain so difficult for physicians to treat? Well, first of all, there's no cure for it. Even successful treatment involves some residual pain. And for those seeking help, they reject the stance that my pain's at a 10, but don't try to get me to do those morning stretches exercises. It discourages a lot of physicians. And there's some negative feedback. Nothing that you are doing as a doctor is helping me. So it's unrewarding for the provider. And they have to consider substance abuse, opioid addiction, diversion, and possible legal sanctions like malpractice suits. And for some PCPs that use acute care strategies for a problem which is a chronic condition, they create a revolving door. That is, giving PRN medications for pain can cause some problems. That is, as needed. Now, for the chronic pain patient, the pain is very real. But what are some of the difficulties faced by a patient who suffers from chronic pain? There's a sense of isolation. They lose contact with their normal day. There's a perception that others don't believe that their pain is real. They feel sometimes that they're promised one thing by a provider and another thing happens. There's a perception that they're viewed as being an addict by others because they have a dependency on opioids. And criticism from family members for variable day-to-day performance. There's some self-criticism for not being able to just power through and rise above the pain. And there are some common morbid states like depression, anxiety, that cause triggers or amplify the pain experience. But what are some of the causes of chronic pain? Well, we know that pain related to the spine is one of the most common types of chronic pain. There's others like headaches, pelvic pain, but there's other causes too, like accidental injury, trauma, infection, cancer, soft tissue conditions, complications resulting from surgery, and sometimes chronic pain can have an onset without an explanation. And some researchers conclude that physiological disorders, including stress and emotional stress, are triggers. And we know that chronic pain is often diagnosed based on its effect on normal function, normal movement, and quality of life. Now, let's take a look at some of the payer methodologies here. You see the major payers, which are Medicaid, Medicare, private insurers such as Blue Cross Blue Shield, Veterans Health Administration. Now, they will pay for medications, some regional anesthetic interventions, surgeries, psychological therapies, rehabilitative or physical therapies, and complementary and alternative medication treatments. They'll pay for these. And again, then they put these in pain-related treatments, and they put them into categories. The same similar things are put into categories. Again, medications, interventions, surgery, psychological therapies. These are some of the methodologies that are used by the major payers. And they also take a look at reimbursement for pain-related treatments, and insurers use a broad range of methods to pay healthcare providers for rendering services, including those related to pain, and some common payment methods include capitated payments. They'll only get one payment for a range of services. Episode or bundle payments, group of providers who do cross multiple settings receive a payment for a group of services related to a patient's treatment or condition. Fee for service, which can be very expensive. Each provider is reimbursed a fee for each service he or she renders. Or prospective payment system, a provider receives a fixed predetermined payment for a specific diagnosis regardless of the actual cost. But what are some of the treatments? Now, we know that there's evidence that narcotics is very limited, particularly when it comes to end-of-state functioning. And SAIDs are more likely to reduce or eliminate pain and should be the first-line treatments. They're non-narcotics. Think ibuprofen. Cognitive behavioral interventions have been repeatedly shown to be effective at improving functional status, but less so with pain. And regimens of exercise aimed at stretching and limbering have been repeatedly shown to reduce the pain and improve some functional status. But let's take a look at pain in its context. Sometimes the unwillingness to have pain leads to refusal to accept the reality of pain, and it's perceived as the main obstacle to vital living. Thus, the goal is to first eliminate the pain, and then vital living can happen. And since pain can't be controlled or eliminated, the paradoxical result is that there's an increasing focus on pain and its elimination. This leads to an ever-widening pattern of behavior designed to control pain at the expense of living a vital life. And what are some of the goals of treatment? Well, first of all, is to promote functional improvement, increase pain acceptance and engagement in life, decrease reliance on long-term narcotics use, identify and manage patients at risk for substance abuse or addictive behaviors, prevent the onset of chronic pain by working aggressively with acute pain patients, and seamlessly integrate behavioral and medical interventions with a single care plan. What are some other treatment considerations? The goal of treatment is not the elimination of pain, but the restoration of functioning. And any treatment that is not improving functional status should not be continued. Long-term narcotics treatment always comes with strings attached, as we know with the opioid crisis in the United States. And evidence-based care is the strongest platform from which to engage the patient. And all chronic pain patients started out as acute pain patients, and thus there must be a place for prevention. Now let's take a look at prescribing opioids for chronic pain. A general CDC guideline is that opioids can provide short-term benefits for moderate to severe pain, and that there's evidence lacking to the benefits to treat chronic pain. And in general, physicians are advised to not prescribe opioids as the first-line treatment for chronic pain. And before prescribing, the CDC advises assessing pain and function, consider if non-opioid therapies are appropriate, and talk to the patients about a treatment plan. And let's take a look at the opioid epidemic costs. And as you can see, 12.5 million people misunderstood prescription opioids. 33,000 died in 1 year from overdosing on opioids. And the bottom line is all these effects have a $78.5 billion in economic costs, and that is a tremendous number. And what are some final thoughts? Well, chronic pain is increasingly being recognized as a public health concern with enormous clinical, social, and economic burdens. There are well-documented disparities in pain assessment and treatment in disadvantaged groups, especially the elderly populations, racial and ethnic minority population, so the urgency of coordinated management of this condition must be stressed among those stakeholders. And because chronic pain is influenced by numerous interacting and contributing causes as well as several effects, pain care must be tailored to each individual's experience. This demands an IDT approach that uses a combination of psychological, physiological, cognitive, clinical, and self-care methods. So with that, thank you very much. That concludes the presentation of this portfolio analysis. Any questions, comments? Thank you very much. And here's a list of references that were utilized throughout the portfolio assignment. Thank you very much.